Yes. Next. Okay. Oh, sorry. Alzheimer. Aspiration pneumonia. Quetiapine. Okay. This patient's acute confusion, fever, tachycardia. This patient's acute confusion, fever, tachycardia, signs of lower lung consolidation, tactile fremitus, dullness, percussion, crackles, suggest community acquired pneumonia. Risk of community acquired pneumonia increased in elderly patients due to age-related impairment in innate and specific immunity. In addition, the use of atypical antipsychotic is quetiapine in elderly patients is associated with a much higher risk of community acquired pneumonia, although the mechanism is unclear. Although the mechanism is unclear, it may be related to cholinergic and histamine receptor inhibition, which causes oropharyngeal dryness, reduced ability to generate food bolus, and increased risk of subsequent aspiration. An additional risk factor in this patient is the presence of dementia Alzheimer's, which includes the risk of aspiration due to impaired ability to protect the airway and coordinate the muscles involving the swallowing. Coordinate the muscle involved in swallowing. Next. Is it normal? Is it sleep study? Okay. This patient has mm, this patient has symptoms of hyperactivity, impulsivity, blurting out answer, hyperactivity, impulsivity, blurting out of answer, and inattention, easy distractibility, often attributed to ADHD in children. However, other medical conditions include conditions, seizures, hearing impairment, can have symptoms that mimic ADHD. An alternate diagnosis should be considered when certain historical clues are present, particularly in a patient with a sudden or late onset adolescent, sudden or late onset symptoms. In this case, these patients' elevated BMI, snoring, and daytime sleepiness raise concern for obstructive sleep apnea. Obstructive sleep apnea is characterized by intermittent airway obstruction resulting in fragmented sleep. Adenoacondylar hypertrophy is often the cause of young children is often Adenoacondylar hypertrophy is often the cause of young children, but obesity is a common risk factor. In adolescent, frequent snoring is typical, but insufficient sleep often leads to napping at unexpected times during school. In some children, presentation may be limited to behavioral problems and symptoms overlapping with ADHD because excessive sleepiness can cause patients to be irritable, fighting with sister, easily frustrated, throwing homework, and impulsive. Finding concerning for USA warrant evaluation with a sleep study before a diagnosis of the ADHD and can be made because treatment with positive airway pressure typically results in improvement of behavioral problem in those with confirmed OSA. Presuming the diagnosis of ADHD without evaluation for OSA may expose patient to unnecessary pharmacotherapy, methylphenidate, and its potential side effect. Next. Yes, yes, I have opened the next block. Okay. Okay. Parental concern about adolescent health should be taken seriously and evaluated in further detail. However, providing appropriate medical care to adolescents typically requires a therapeutic alliance between the physician and the adolescent. Adolescents tend to place a high priority on confidentiality and are more likely to be honest if they believe that their privacy will be safeguarded. Therefore, in situations involving sensitive topics, substance and tobacco use, sexual activity, physician should interview the patient alone. In this scenario, the patient's frequent asthma exacerbation are likely secondary to personal tobacco use. However, physicians should avoid bringing up sensitive topic before addressing them confidentially with the patient except in life-threatening or dangerous situations, suicidality or abuse. This is because direct your daughter may be smoking or indirect have you noticed her clothes smell like cigarettes accusing are likely to alienate alienate that loosen and shut down further communication. Finally, the patient's concern and natural desire to be the part of the child's care can be framed in an inclusive rather than antagonistic manner, and that is, and then we can all talk about treatment plan together. The primitively limits confusion and avoids unintentionally offending the parent. Okay. Okay. This patient with well-controlled rheumatoid arthritis has several months of progressive right shoulder pain relating to the arm, although physical examination of the right shoulder is normal. In the presence of ipsilateral meiosis and ptosis and has a long history of smoking raises strong suspicion of Horner syndrome due to superior pulmonary sulcus tumor. Superior pulmonary sulcus tumor arises in smoker. Most cases are caused by adenocarcinoma or squamous cell carcinoma of the lung. Because the superior sulcus is located in the lung periphery, pulmonary symptoms such as dyspnea, hemoptysis, cough do not generally occur until late in the disease occurs. Therefore, most patients common to clinical attention due to symptoms related to invasion of the structure, including shoulder pain, due to invasion of the brachial plexus or adjacent bony structure, Horner syndrome, meiosis, ptosis, and hydrosis due to invasion of the paravertebral sympathetic chain or cervical ganglion, arm or hand weakness in an ulnar deviation, weakness in intrinsic hand muscle due to invasion of the C8 and T1 nerve root. Patients with suspected superior sulcus tumor should undergo chest imaging, chest X-ray, followed by staging imaging and biopsy if a lesion is found. Okay, okay. This patient has pancreatitis, respiratory failure, most likely due to ARDS. The assist control mode of mechanical ventilation. The assist control mode of mechanical ventilation delivers a predetermined tidal volume with every breath. Inspiratory cycles can be initiated by the patient, but if the patient fails to breathe at a minimum rate, then the ventilator will deliver the tidal volume on its own. In general, tidal volumes should be about 6 ml per kg ideal body weight. Thus, the tidal volume being administered to the patient above is appropriate. However, the arterial blood gas increase pH more than 7.4 and decrease PCO2 consistent with respiratory alkalosis secondary to hyperventilation. Thus, decreasing the respiratory rate would be Decreasing the respiratory rate would be most appropriate step in the management. Next, is it laryngomalacia? Inspiratory stridor. Mm, crying results at rest. If he cries, this group. Okay. This patient with upper respiratory symptoms, congestion, rhinorrhea, now has harsh cough and inspiratory stridor. Symptoms suggest of croup. Croup is a viral. Croup is Croup is common viral infection in young children 6 months to 2 years, predominantly caused by parainfluenza virus. The virus spreads from nasopharyngeal mucosa to the larynx, subglottis, and proximal trachea, causing edema and narrowing. The inflammation of the cricoid cartilage within the larynx create a partial upper airway obstruction, resulting in high-pitched noise during inspiration, hoarseness, and a barky cough. The stridor is primarily inspiratory due to decreased intratracheal pressure with inspiration, causing further narrowing and transient airway collapse. Because the airway diameter in older children and adults is larger, upper respiratory infection typically occurs in the absence of obstructive symptoms. The diagnosis of the diagnosis of croup is usually clinical, but X-ray obtained for atypical symptom may reveal subglottic narrowing and stipples, and treatment includes corticosteroid to reduce subglottic edema as well as nebulized racemic epinephrine for severe cases. This is the stipple sign. Okay, subglottic and proximal trachea narrowing. Yes. Inflammation of the epiglottis and inflammation of the epiglottis and aryepiglottic fold Describe epiglottitis, a severe infection usually caused by Haemophilus influenza type B. It is rare in immunized children, although patients often have stridor and respiratory distress. They typically appear ill and have a high fever, difficulty swallowing, drooling, none of which are seen in this patient. And foreign body aspiration patient, foreign body aspiration patient presents with sudden onset respiratory distress, often following an acute choking episode. Laryngeal foreign body may cause inspiratory stridor, but bronchial foreign body cause focal wheezing and asymmetric breathing sounds not seen here. These patients' congestion and rhinorrhea also make an infectious cause more likely as foreign body. Okay. Okay. Management of drowning. Management of drowning, administer acute intervention, administer rescue breaths first, then chest compression for cardiac arrest. Remove wet clothing to improve hypothermia. Transport to emergency department. Emergency department care. Emergency department care symptomatic. Maintain oxygen and ventilation. Continue cardiopulmonary monitoring. Supportive care as needed. That is supplemental oxygen, bronchodilator, NIV, and intubation. Evaluate chest X-ray, ECG, ABG, CBC, electrolyte, drug screening in adolescent or adult asymptomatic patient. Observe more than 8 hours. Continue cardiopulmonary monitoring. Monitor for signs of ARDS and dyspnea, wheeze. Evaluate chest X-ray at end of observation to assess for pulmonary edema with or without ABG, CBC, electrolyte drug screen. This patient who experienced non-fatal drowning and is now alert and well appearing with normal vital signs and a normal physical examination. However, he is at critic he is at risk for developing delayed pulmonary complication, of large amount of large amount of fluid often occurs during drowning, even if the fluid is coughed out quickly, as in this patient did, and normal ventilation is restored. The fluid may have already caused damage capable of resulting in delayed pulmonary complications. The damage may include direct tissue injury from chemicals or contaminants in the fluid leading to inflammation, washout of alveolar washout of alveolar surfactant leading to alveolar collapse, disruption of osmotic gradient of the alveolar capillary membrane leading to increased fluid permeability. Together, these insults can progressively impair exchange, uh, oxygen exchange and can cause atelectasis, decrease lung compliance, and non-cardiogenic pulmonary edema. Without treatment, these complications can rapidly progress to life-threatening and acute respiratory distress syndrome. Most asymptomatic patients who develop delayed pulmonary complication exhibit symptoms within first 8 hours. Therefore, they should be closely observed and the emergency department or another hospital unit rather than discharge home for at least that long. At the end of the prolonged observation period, chest x-ray should be repeated. If it is normal, then the patient remains asymptomatic with normal vital signs including oxygen saturation, and the patient can be discharged. Okay. Okay. This patient ECG findings are consistent with multifocal atrial tachycardia. MAT is a supraventricular tachyarrhythmia, likely occurs due to an atrial conduction. Abnormalities triggered by disturbance such as right atrial enlargement, catecholamine surge, sepsis, or electrolyte imbalance. It is most commonly seen in elderly, age more than 70, with an acute exacerbation of underlying pulmonary disease (COPD). Patients typically have symptoms of the underlying disturbance, cough, wheezing, shortness of breath, and the tachycardia itself is usually asymptomatic. Cardiac examination in patients with MAT reveal uh, should reveal in an irregular rhythm with rapid rate. The diagnosis is confirmed by ECG showing distinct P wave of three or more than three different morphologies, irregular RR interval and the atrial rate, irregular RR interval and atrial rate. The best treatment is appropriate management of the inciting disturbance, the administration of bronchodilation, systemic corticosteroid, supplemental oxygen ventilatory support for these patients. Acute exacerbation of the COPD can lead to resolution of multifocal atrial tachycardia. Okay, sorry. Yes. Mouth. Okay. This patient has been prescribed a combination of the inhaled steroid and long-acting beta agonist, as initial therapy for persistent asthma. Inhaled corticosteroid have both local and systemic adverse effect. Local effects. Approximately 75% of the inhaled corticosteroid is deposited. um Inhaled corticosteroid is a deposited of deposited of target in the oropharynx and the supraglottis. Okay. The topical steroid exposure causes dysphonia due to myopathy, laryngeal muscle, and suppression of mucosal immunity predisposed to oropharyngeal candidiasis. Spacer devices can minimize the local deposition of the drug particles, reducing the incidence of local adverse effect. Rinsing with water, gargling, and expectorating after inhaled corticosteroid use further reduces the risk of oral thrush. Systemic effects. The remaining dose, 25%, settles in the lower bronchi and lung periphery, exerts his therapeutic effect, and subsequently absorbed in the systemic circulation. Systemic toxicity reflects the broad activity of the glucocorticoid and includes adrenal suppression, Cushing syndrome, osteoporosis, cutaneous changes, easy bruisability, ocular effect, ocular effects, cataract and intraocular hypertension, pulmonary immunosuppression increase the risk of pneumonia. Therefore, inhaled corticosteroid has low viability overall, particularly because any locally deposited steroid that is eventually swallowed is inactivated and bypassed by the fast metabolism in the liver compared to the local effect. Systemic adverse effect typically seen only in patients with high dose inhaled corticosteroid more than 800 milli mcg, more than 800 mcg per day fluticasone equivalent for prolonged duration, several years to decades, concurrent use of systemic steroid, frequent oral prednisolone bursts, or medication that interfere with steroid metabolism. Ritonavir, itraconazole also predispose patients to systemic toxicity. Both local and systemic adverse effects are increased with higher inhaled corticosteroid dose. However, due to poor systemic bioavailability, local adverse effects are far more common than systemic ones as given in inhaled corticosteroid. Therefore, this patient is much more likely experience local adverse effects such as dysphonia or oral thrush than any manifestation of systemic hypercortisolism. Next, yes, adverse effect of inhaled corticosteroid. 70% of dose deposited in the oropharynx, dysphonia thrush can happen. 25% of the deposited in the peripheral lung and systemically absorbed. HPA axis, like secondary adrenal insufficiency, can coexist with inhaled corticosteroid. Cushing syndrome, skeletal small with increased osteoporosis and fracture risk. Other like dermal thinning, ocular effect, and small increase in or and small increase in community acquired pneumonia risk in patients with COPD. Okay. Okay, SPN, solitary pulmonary nodule on routine X-ray. If you find a solitary pulmonary nodule on routine X-ray, uh, previous X-ray should be seen. Stable lesion over 2 to 3 years, no further testing, and no previous imaging or possible nodule growth. CT scan. If it is chest CT, if it is benign feature, serial chest scan. If it is indeterminate or suspicious for malignancy, further intervention with biopsy or PET positron emission tomography. If it is high suspicious for malignancy, surgical excision. A solitary SPN is defined as the features of round opacity up to 3 cm in diameter surrounded by pulmonary parenchyma. By convention, there must be no associated pleural effusion, adenopathy, and atelectasis. Incidental, most incidentally discovered SPN are benign, infectious granuloma, hematoma. However, it is most important to differentiate benign from malignant nodule. Bronchogenic carcinoma metastasis. The first step in evaluating SPN is comparison with previous X-ray. If a solid lesion revealed on prior imaging is stable in size more than 2 years, malignancy is effectively ruled out, and no further testing is necessary. Malignant nodule tend to double in size over the course of month or year. If if no previous radiographs are available for comparison, HSCT should be performed to further characterize HSCT should be performed to characterize the lesion. CT provides greater detail of a lesion size, border density, large lesion, low density, speculated border, and eccentric calcification favor carcinoma. Large nodule, low density, and speculated border and eccentric calcification favor carcinoma. Once, yes, I have serious problem. If no previous radiographs are available for comparison, HSCT should be performed to further characterize the lesion. CT provides greater detail of a lesion size, border, and density, large nodule size, low density, speculated border, and eccentric calcification favor carcinoma. Other clinical characteristics suggest malignancy include age more than 40, history of smoking, weight loss, favor malignancy, nodules with high overall risk for malignancy should be excised. Those with low malignant potential should be allowed with serial CT scan. The exact interval of imaging depends on patient and nodule characteristics. Okay, next. Okay, left lateral decubitus. Okay, this patient with sudden onset respiratory distress following removal of a central venous catheter has most likely developed a venous air embolism. The venous circulation is susceptible to air embolism. The venous circulation is susceptible to air embolism due to relatively low intravascular hydrostatic pressure. Venous air embolism travels to the right ventricle. Venous air embolism travels to the right ventricle where it can obstruct the right ventricular outflow tract, or it can travel further to the pulmonary arterioles where it can obstruct pulmonary capillary blood flow, leading to ventilation perfusion mismatch and hypoxemia. Obstructive shock and cardiac arrest result. Patient with suspected venous Patient with suspected venous air embolism should immediately placed in the left lateral decubitus position or left lateral Trendelenburg, left lateral decubitus with head down, which traps the venous air embolism on the lateral wall of the right ventricle, preventing right ventricular outflow tract obstruction and further embolization of the vena of air into the pulmonary circulation. High flow oxygen in severe case and hyperbaric oxygen is important as it shrinks the air embolus by encouraging the absorption of the nitrogen gas, the main component of the atmospheric air in the blood. Okay, if there is any venous air embolism, like when removing the central venous catheter, if somebody develops these sudden severe shortness of breath, JVB distended, then we just place the patient in the left lateral decubitus or Trendelenburg position, isn't it? And we will give high flow oxygen. Is it core pulmonary? He has features of left heart failure, features of right heart failure. Okay. Okay. Cardiogenic pulmonary edema. Okay. Effects of positive pressure ventilation. in cardiogenic pulmonary edema? First, look at the box. If there is any increase intrathoracic pressure, if there is increase intrathoracic pressure, it will decrease right ventricular preload and increase right ventricular afterload, which will decrease the left ventricular preload. Okay, if there is any increase intrathoracic pressure, it will decrease the mean arterial pressure. It will decrease the left ventricle transmural pressure gradient, which will decrease the left ventricular afterload. So left ventricular preload is decreased, afterload is decreased. So increase left ventricular performance, which leads to pulmonary congestion, increase left ventricular performance, pulmonary congestion, increase PaO2, and increase left ventricular performance. It will increase the cardiac output and increase the end organ oxygen delivery and survival. An increase in intrathoracic pressure displaces interstitial lung water, which will increase PaO2. Okay, haven't gotten. Okay, the, this patient this patient has acutely decompensated left heart failure, acute decompensated left heart failure with cardiogenic pulmonary edema. S3 crackles hypoxemia. Treatment of cardiogenic pulmonary edema is directed at improving the left ventricular performance. Possible positive pressure ventilation (PPV) optimizes the hemodynamics to achieve this goal. Pressure is applied 5 to 20 centimeters applied to the patient's airway and usually non-invasively through a mask. Positive pressure ventilation decreases left ventricular preload through the following series of events. Application of positive pressure ventilation directly raises the increase directly raises the intrathoracic pressure, causing a drop in venous return to the right heart, decreasing right ventricular preload. Elevated intrathoracic pressure compresses the alveolar capillaries, raising the pulmonary vasculature resistance, increased right ventricular afterload. So what is happening? Okay, due to these effects, there is less blood volume returning to the left atrium. Left ventricular preload is low in decompensated heart failure. Left ventricular end diastolic volume is high. Lowering left ventricle Lowering left ventricular preload shrinks the ventricular cavity size, leading to more dangerous Frank-Starling relationship, improved myofibril overlap to promote systolic ejection. Positive pressure ventilation also decreases left ventricular afterload through two mechanisms to eject mechanism to eject blood during systole. The left ventricle must overcome two components of afterload: the aortic pressure, the mean arterial pressure, and the left ventricular transmural pressure gradient. Positive pressure ventilation decreases mean arterial pressure through baroreceptor effects by lowering adrenergic tone through decreasing neurohumoral activation. This is particularly helpful with superimposed hypertensive emergency, as in this patient. Positive pressure ventilation decreases left ventricular transmural pressure because as the positive pressure is transmitted to the pleura, the left ventricle contracts against the small transmural pressure gradient. This is especially beneficial in pulmonary edema, where massive inspiratory efforts generate deep negative pleural pressure to impede the left ventricular contraction. Therefore, positive pressure ventilation lowers left ventricular preload and left ventricular afterload. In patients with decompensated heart failure, this optimizes left ventricular function across the entire cardiac cycle. There is enhanced stroke volume in systole and impaired filling in diastole, resulting in decongestion of the lung forward for decongestion in the lung forward cardiac output. Although with increasing left ventricular volume, positive pressure ventilation displaces the intrinsic lung water to improve oxygenation. Because cardiac output and oxygenation are both augmented, and the overall effect of PPV is to increase the global oxygen delivery to end organs. For this reason, PPV has major mortality benefit in cardiogenic pulmonary. Okay, I'm coming. 2 minutes. Hello, hello. Can you hear me now? Hello, hello. I can't hear you. Yes, now. What happened? I don't know. Sorry. Looks like apnea. Is it uh, transient? Okay. It is bronchiolitis. Okay. This neonate has cough rhinorrhea. This neonate has cough rhinorrhea and lung finding consistent with bronchiolitis. A common respiratory infection. A common respiratory infection in children aged less than 2 that affects the bronchioles. Respiratory syncytial virus is the most common cause of bronchiolitis and occurs most often in the late fall and winter. In older children aged more than 2, respiratory syncytial virus is generally a mild self-limiting upper respiratory tract infection, congestion, rhinorrhea. However, infants and young children tend to also develop inflammation of the lower respiratory tract resulting in wheezing, crackles, and respiratory distress. Tachypnea, hypoxia. Fever may be present early in the illness, and respiratory symptoms usually peak around 3 days 3 to 5. Diagnosis is clinical and treatment is supportive hydration, saline, suction, supplemental oxygen. Most children fully recover within 1 to 2 weeks. However, bronchiolitis can be complicated by apnea and respiratory failure, particularly in infants aged less than 2 months. Other populations Other populations are at higher risk of complication from bronchiolitis include premature infants and patients with hemodynamically significant cardiac disease, chronic lung disease, immunodeficiency. Less severe complications of bronchiolitis include dehydration and aspiration pneumonia. Okay, look at the box. Bronchiolitis, viral induced inflammation of small and distal airways, bronchiolar obstruction from sloughed epithelial cell, leukocytes, mucus. Respiratory syncytial virus, most common cause, age less than 2, antecedent nasal congestion, rhinorrhea, cough, wheezing and crackles, tachypnea, retraction, peak severity, days 3 to 5, hypoxia plus fever. Radiologic finding, bilateral hyperventilation, bilateral hyperinflation, increased interstitial marking, peribronchial coughing, supportive nasal suctioning, hydration, and supplemental oxygen, complication apnea less than 2 months, and respiratory failure. Prevention is need semi-vab for all children age less than 8 months. Okay, the rapid onset hypoxemia with diffuse bilateral opacities typically reflects fluid cells, blood. This patient history of recreational drug use paired with symptomatic toxidrome and cicatrix burns raises concern for acute inhalation cocaine-induced lung toxicity, cracked lung causing diffuse alveolar hemorrhage bloods. Co- Sorry. Cocaine can be insuffled, snorted, or inhaled. Central stimulation of sympathetic outflow causes hypertension, tachycardia, mydriasis. Burns occur due to handling Burns occur during handling of the hot pipes, while nociception is blunted and are a specific indicator of inhalant use. When inhaled, cocaine undermines the blood-alveolar barrier via thermal damage, scorching, hot smoke, ischemia, reperfusion injury, intense pulmonary vasospasm, and direct cellular toxicity. This can result in DH, a form of widespread alveolar capillary bleeding. Respiratory symptoms begin within 48 hours of smoking cocaine. A clinical diagnosis is made on diffuse pulmonary opacity and suspected recent inhaled cocaine exposure or u, positive urine drug screen. Because the bleeding occurs deep in the lungs, hemoptysis may be absent in half of the patient, although not usually needed. Bronchoscopy with serial lavage and shows a sequentially bloody vials differentiating DAH from non-alveolar sources aspirated blood. Next, what is your diagnosis? Sorry, maybe. Sorry, no, no. It is pulmonary embolism. It is PE. So this patient's acute dyspnea, chest pain, likely, most likely due to pulmonary embolism in the setting of DVT, given her right leg swelling bilateral, wheezing can occur acute PE due to cytokine-induced bronchoconstriction in response to hypoxia and infarction. Her risk factor for DVT or PE should uh, PE include obesity, BMI more than 36 kg per meter square, potential endometrial cancer. PE causes ventilation perfusion mismatch, resulting in increase from the expected oxygen gradient. Oxygen alveolar oxygen PaO2 is calculated PaO2 equal to FiO2 into PATM. minus P water minus PaCO2 divided by 8, where FiO2, okay, there is calculation, okay, where FiO2 fraction of inspired oxygen, PATM, atmospheric pressure, water vapor pressure, PaCO2 partial arterial pressure of carbon dioxide obtained from ABG. This simplifies alveolar oxygen equal to 150. Inspired oxygen is 150, where it is written, okay, it is 150, minus PaCO2 divided by PaCO2 divided by zero point 0.8 for the breathing room air at sea level. The AA gradient is then calculated by subtracting alveolar oxygen minus arterial oxygen, where alveolar arterial oxygen is also taken from the ABG. AA gradient, if it is greater than expected AA gradient on room air, it is estimated by 2.5 plus 0.21 into patient's age, or patient age by 4 plus 4. AA gradient evaluation is in the process can causes impaired gas exchange. Okay, his age is 48. 4 by 4, 4 plus 4, 1 to 12, 16. So AA gradient is increased. Got it? I have an understand with that anything else with that calculation. I have got the idea. Okay, it is pulmonary embolism. So high A gradient is calculated by 4 patient age, patient age by 4 plus 4. 8. That's it. Next, is it tracheal stenosis? Oh, may not be persistent. It is not persistent asthma, not pulmonary fibrosis, not bronchoconstriction. Maybe, or it is either D or E. Mm, looks like tracheal stenosis. It is tracheal stenosis. It is a memorization question. Okay, I remembered by visualizing the answer, because obstructive pattern is scalloped, or like, okay, okay, I'm reading the explanation. This patient required this patient required intubation and mechanical ventilation for a severe asthma exertion. Prolonged intubation or high endotracheal tube cuff pressure can cause ischemic injury to the tracheal mucosa. The resultant scar results in tracheal stenosis, which can evolve, which can evolve months after the injury, as airflow is directly proportional to the radius to the fourth power. The patient may need substantially narrowed for symptoms onset to occur, composed of rigid scar tissue. The tracheal stenosis is fixed upper airway obstruction with fixed narrowing. The airflow is reduced equally across the respiratory cycle, both inspiration and expiration. This leads to characteristic flattening of the flow volume loop, characteristic narrowing of the flow volume loop on pulmonary function testing. Flow through the narrowed segment becomes turbulent, generally audible noisy sounds during inspiration and expiration biphasic straddle. Additional fixed airway obstruction include extrinsic compression, extrinsic compression from the neck or mediastinal masses, malignancy, thyroid disorder, and developmental abnormalities. In bronchomalacia, look at the pattern of the bronchomalacia. How I will remember the bronchomalacia. Okay, bronchomalacia is lower portion is slightly curvy, not like this. Variable intrathoracic obstruction. Look at the asthma. There is in asthma increased residual volume, so there is air trapping. So decrease vital capacity. How you remember these patterns? What's your technique? Just reading will not gonna improve the problem. Okay, I will not gonna understand just reading the explanation because I have read plenty of time. Do, do you want me to read the explanation? Which one you want to? Okay, we have understand the tracheal stenosis, isn't it? Okay. Next, or we will catch tomorrow. I have seen all the thing, but I don't know how to remember. Is there any technique of remembering like you remember in? Okay, then we can do it tomorrow. Okay, bye bye.